welcome everybody to this. I think it's the fourth in our series of webinars, Coronavirus, Capitalism and Global Inequality. We actually kicked off with the first one of our webinars on the 28th of March. And since then we've done a few more. But in that first webinar, Heidi here, who's one of our speakers today, talked about the campaign that we've been running for a few years now over access to medicine and over the frankly kind of corporate profiteering of the pharmaceutical industry and trying to, and the way that affects people's right to health all around the world. That was just one of the topics that we dealt with in that first webinar. So we wanted to come back to that in the series and look at that again, and of course specifically look at it in relation to coronavirus, because we're now involved in a global campaign to try and ensure that the treatments and any vaccine that are developed around to treat COVID-19 are genuinely available to all. Heidi's going to speak about that in a moment. We're also really pleased to welcome two more speakers joining us from South Africa and from Brazil, who have both got their own long history of campaigning on access to medicines. So they're going to tell us about some of those experiences and how that how that relates to the struggle for access to coronavirus treatments all around the world. So I will in a moment hand over to them, but I just want to first of all say a little bit more about who they are. I'll do that for all three of them at the beginning, and then we'll move straight into them talking for a few minutes, and then of course after that we'll do some questions. Well, I'll bring in some of your questions, and we'll have an ongoing conversation. So first of all, we're going to hear from Heidi Chow, who is a senior campaigner at Global Justice Now. I should say, for those of you who don't know Global Justice Now so well, we're a campaigning organisation working on global economic justice issues, particularly, although not exclusively, as they relate to people in the global south. And we're made up both of local activist groups around the country who do everything from street stalls, normally, not at the moment, obviously, to lobbying their MPs and putting on events, and also campaigners and organisers who are employed by the organisation, like me and like Heidi. And I am James. I'm the head of activism. So I didn't remember to introduce myself either at the beginning. Back to Heidi. Heidi's a senior campaigner on access to medicines and the pharmaceutical industry at Global Justice Now. And she's also previously been a campaigner on trade justice and food sovereignty with us. And as well as leading our campaigning, she was a co-author on the two reports that we've put out during the course of the campaign, along with allies. Pills and Profits, which was about what was wrong with the pharmaceutical industry, and the second one in 2018, the People's Prescription, which was more about some of the solutions that we were looking at. So that's Heidi. Secondly, we're going to hear from Umunyana Rugege, who's the Executive Director of Section 27, which is a human rights organisation based in South Africa. She's a human rights lawyer herself, and has played a leading role in a number of high-profile cases in South Africa. Has worked on access to medicines for many years. She was an attorney in a case involving access to cancer medicines, and she's also been leading policy work to change intellectual property laws in South Africa. And then finally, we'll hear from Pedro Villard, who is a project coordinator at the Brazilian AIDS Interdisciplinary Association. And he also coordinates the working group on intellectual property in Brazil, where he's been at the forefront recently of the push for a suspension of patents for any pharmaceutical products which could be used to fight COVID-19. Without further ado, I'll ask Heidi to talk about our campaign and what we've been doing. Heidi.
Thank you, James, and thank you everyone for taking up your time this evening to join us and to hear about the struggle for access to medicines, both here in the UK and around the world. I do feel really privileged to be chairing a panel this evening with Umunyana and with Pedro. I just want to say solidarity to you guys. We're in the same struggle. I don't know about you guys, if you've followed the news, you would have seen that a lot of talk this weekend about whether the lockdown measures are going to be lifted in some way. But actually right now, the only really sustainable way to end this global pandemic is a discovery of a vaccine, essentially. And so the world is pinning their hopes on a COVID-19 vaccine. And there are currently about over 70 different vaccine projects in the world. But unfortunately, a vaccine breakthrough is going to be challenging, but it's only going to be the first part of that challenge. We also need to mount a fight right now to ensure that any vaccine developed will be affordable to all countries and free to the public. Because sadly, this is not going to happen by default. And this is because we have a pharmaceutical system that is driven by profit and not by public health. And so Big Pharma makes decisions about what drugs to develop based on the areas of greatest profitability rather than the areas of greatest health needs. So for example, only 4% of new drugs that are brought to market are for conditions that affect people in the global south. In other words, these markets are considered to be too poor for Big Pharma to make a profit from. And this is also the reason why we've seen insufficient investment into developing new antibiotics. Again, this is seen as an unprofitable area. So even though humanity is facing a resistance crisis to antibiotics at a level that would be catastrophic, Big Pharma again deemed this not to be an area that is profitable for them. And then vaccines are also seen as an area of low profitability as well. Traditionally, Big Pharma likes to invest in chronic conditions like cancer and diabetes because you can, these are the sort of medicines that people take over long periods of time. And so this tends to be more profitable than investing in vaccines, which is about preventing diseases. And so the other aspect of why Big Pharma haven't been that interested in vaccines as well is because vaccines for infectious diseases like coronavirus can actually take a long time. Sometimes you need to wait months, even years, to see whether human trials have worked and also to check whether there are any damaging side effects. And so by that time, the crisis might have gone past, and with it the demand for a vaccine. And so it's been seen as a costly risk for Big Pharma, which is why in recent years the industry has been consolidating. And so there's only really there's only 4 big firms that take up about 90% of the market share. And so there's this fundamental tension in the system between public health and profits. And this tension and these flaws in our system are really come to the surface and really visible during public health crises. So for example, the Ebola epidemic from 2014 to 2016, it killed over 11,000 people. But prior to that outbreak, there had actually been a vaccine breakthrough for Ebola. But because there was no promise of financial returns, because it didn't feel commercially viable, because the people it was affecting were people in sub-Saharan Africa and small villages, this breakthrough was left on the shelf, gathering dust with no real other commercial interest or further investment to actually test and produce that vaccine. And so when the epidemic broke out in 2014, there was no actual vaccine available. There was also a promising SARS vaccine as recently as 2016. And the genome of SARS has a very high degree of similarity with the COVID-19 genome. And so actually that particular vaccine could have been a potential coronavirus vaccine. But again, because the SARS pandemic had long passed back in 2003, in 2016, there was just no more interest in developing this. And actually, one of the leading scientists on that project actually testified in Congress just as recently in March to say actually that we could have had this vaccine ready to go back in January when it first broke out in China. And so this lack of interest in vaccines has meant that public funding plays a really huge role. And ever since the outbreak of the coronavirus, it's played public funding has been pouring in to shore up the investment into vaccine development. So just this past Monday, the EU and the UK and other countries globally hosted a global fundraising summit to appeal for pledges from governments to raise money to pour into vaccine research and development. They raised £6.5 billion, and of that the UK contributed 544 million, the EU contributed £1 billion. And public funding already has a big role in our system. It already has, we already see academic estimates which show that about 1/3 to 2/3 of all global R&D is funded by the public purse. However, what happens is that Big Pharma takes publicly funded research and develops and then markets those final drugs. And because they do that, they're able to patent new drugs. So this means that no one can make or sell that drug for a period of at least 20 years. And so with no competition, pharmaceutical companies can essentially charge whatever price they want. And we've seen the impact of high drug prices throughout the last few decades, and especially in the global south. But over the last few years, we're seeing the impact also hit middle-income countries, high-income countries. Even in here in the UK, the NHS is having to increasingly ration or reject drugs because they're just too expensive for the NHS. And so there is and so we've seen communities across the world struggling to access life-saving treatments for things like hepatitis C, for HIV, for cancers. And yeah, and then the thought of watching loved ones die, knowing that there's a drug out there that can save them, but it's completely out of reach because of pricing. So the system is broken at the best of times. It's not delivering the drugs that we need, and when it does, it's at prices that we can't afford. And in the current pandemic, unless there's global collaboration and government intervention, actually this system is not going to deliver us the vaccines and the treatments that everyone will need at the prices that countries can afford. Because patenting a COVID-19 vaccine would essentially enable Big Pharma to engage in to charge high prices, to price gouge, to profiteer, but it could also actually restrict the production volumes of any potential vaccine, because if it's patented, it means that only one company can then make and distribute that drug or the vaccine. And so apart from prices and patents, the other big issue that's going to prevent fair access to a vaccine for all is going to be nationalism. And this is where governments secure supplies for themselves first. And given that most manufacturing facilities are in the global north, there's a real danger that countries could prevent the export of vaccine supplies. And if a vaccine is produced in another country, rich countries can also, might also engage in purchasing up vaccine supplies in advance and hoarding supplies. And this happened in the 2009 H1N1 swine flu pandemic. So rich countries bought up supplies of the vaccine for H1N1 in advance. and it left countries in the global south with very limited supplies. And then in the end, these rich countries, the WHO had to enter negotiations to kind of ask rich countries to donate the vaccines to two countries in the global south, and they only did it in the end because they realized they had too much stock for their own countries when they'd satisfied sort of their own public health first. And so, you know, this emerging vaccine nationalism that we're seeing is not just questionable from a global justice and from an international solidarity perspective, but it's also highly counterproductive from a public health perspective. If a country tries to slap an export ban, for example, from exporting a vaccine, actually there are other countries involved in the supply chain who could also retaliate. Also, a more effective vaccine could actually emerge from a different country. But also we've seen that in this global pandemic that failing to include countries in the global south is completely short-sighted. Actually, this pandemic has shown us that we need a community response to tackling it, and actually failing to immunize people in lower income countries actually creates the risk of a coronavirus being maintained in the global community. And so all of this shows us, first of all, that we can't leave Big Pharma to its own devices and expect Big Pharma to come up with the answers. But secondly, it shows that we also have to challenge nationalistic tendencies. We need global collaboration, and we need government intervention, and we need mandatory binding actions on Big Pharma. So Global Justice Now, we've been campaigning on this since the outbreak of the coronavirus, and we've been pressuring the UK government over 4 specific asks. So firstly, we've been asking the UK government to attach conditions to all of the public funding that they're committing to vaccine research. And we're saying that those conditions need to specify that any publicly funded vaccine is patent free. We're also saying that those conditions need to enforce transparency over prices and costs, and conditions also need to specify that there needs to be mandatory knowledge sharing and technology transfer, so that the clinical trial data, the know-how, the technological know-how, all of that is open source to enable other countries to also develop that kind of capacity. Secondly, we're also asking the UK government to commit to suspending patents. Some COVID-19 treatments are currently being tested. They're existing treatments which are under patent, and they're being tested to see whether they can be repurposed to be used for treating COVID-19. And governments can suspend patents under World Trade Organization rules, and this is called compulsory licensing. So governments can override an existing patent to allow other manufacturers to produce cheaper alternatives. Thirdly, we're working within the global movement to campaign for a global pooling mechanism hosted by the WHO. This would enable the pooling of the vaccines and treatments and their data and the know-how and the knowledge and the data associated with them, so that any WHO member can access the health technologies that they need. And then fourthly, we're also calling for global collaboration to ensure fair allocation of vaccines and treatments, as well as ensuring manufacturers reserve supplies for countries in the global south. So that's an overview of some of the issues that we'll be talking about this evening, a sense of where our campaign is heading towards. And I do encourage you to join our campaign. I believe Liz is going to be posting up some links on the chat. Yeah, and happy to take some questions later on as well. Thank you.
Wonderful, thank you, Heidi. And I'd like to just take this opportunity to say, before we move on to hear from the other speakers, that if you support that campaign and you're not yet a member of Global Justice Now, then do consider joining us, because we're a membership organisation. The majority of our funding comes from lots and lots of thousands of individual members all around the UK. So do join us if you aren't a member. You can do that very easily from our website, globaljustice.org.uk, where you can also find our petition if you didn't sign that already. But without further ado then, I'd like to invite Umunyana to speak.
Thanks to Global Justice Now for inviting me to join this panel. It was really interesting to hear about your campaign from Heidi, and there are lots of parallels with what we've been doing over the years in South Africa. And I look forward to hearing from Pedro as well. There are definitely some links there. So I've been asked to speak about the access to medicines movement in South Africa, and kind of link that to the struggle now around the COVID-19 pandemic, and the kinds of strategies that we've learned from our past campaigns, and bringing them into the kind of struggles today, which are very much the same, and that's what I'd like to talk about. And in some ways, you know, the struggle continues. As much as we do have in our campaigns globally, have victories, gaining access to medicines for HIV, for tuberculosis, getting access around expensive drugs for cancer, and so on. There are these kinds of victories, but at the end of the day, there will always be struggles around access and barriers to access, which include patents, as Heidi has spoken about, but also include policy barriers and access at the points, you know, in health facilities. In South Africa, we have a huge burden of gender-based violence, which in some ways has become its own driver of HIV. And so there's a need for a constant monitoring of the HIV program, despite the fact that we now have the drugs in the country. Those drugs are affordable in South Africa. And in fact, we have access to some of the cheapest ARVs for treatment of HIV in the world. And that's as a result of the struggles over the years that we have waged in South Africa. And I think just, you know, to start, it was 20 years ago now that we had a huge epidemic of HIV in South Africa. People were dying in droves, and there was simply no access at all within the public sector in South Africa. And so there were a few people who were accessing through the private health sector, were able to access drugs because they could afford it. But the vast majority of people who were young people and poor people could not access those drugs. And in some ways, right now, we're in a very similar position where there's a great fear of death as a result of COVID-19. And there's this great hope of vaccines and treatments. But again, at the same time, the possibility of accessing that treatment or vaccines is very low in Africa. And there's several reasons for that, and some of those are historical. So just to talk about some of the strategies that we've used over the years, over this 20-year period to gain access to medicines. You know, the tools that are used by activists everywhere, including protest. And protest is an important strategy that works very well to raise awareness amongst the population, particularly where there's a great divide between the rich and the poor, and where parts of society don't understand the issues that are faced by another part of society. And so protest is an important tool that we've used over the years to raise the profile of these issues and gain public trust and public support for the campaigns that we work on. Another strategy, which I think is really critical now, is community education. Understanding the science around HIV was critical to the fight for life-saving medication in South Africa. I think what was so key was for activists, many of whom were not educated, to actually understand the science and to be able to teach each other in their communities about what HIV was, how it worked, how it was transmitted. And so the treatment action campaign was born out of this need for poor people to respond directly to the issues that were affecting them and that were killing their communities. And so that kind of education and understanding is absolutely critical now with COVID-19. There's so much misinformation that we're having to combat to understand how this works. And also part of understanding how these diseases work is empowering people to be able to hold power to account. So you can't hold your government to account if you don't really understand how things work, how the policy environment works, how the legal structure works, what a state of emergency actually means in your country, and how rights actually play a role in times like these where there is an emergency. So that kind of literacy, I think, is really key. And there's so many organizations around the world that are producing these materials. We've produced materials about COVID-19 in different languages. And some of you may not know that South Africa has 11 official languages. So that's a lot of translating to be done. But really using social media and using community radio, because that is such a powerful tool, and speaking to people in their own languages to understand what is happening in the country, what does the level 4 alert system mean, where are we at in terms of our response, really empowers people. And that continues to be really a critical strategy for activists around the world. And the last strategy, just to talk about in more detail, is the use of the law and litigation. And in South Africa, that was one of the critical tools to both gain access to medicines in terms of facility side medicines, but also fighting big pharma, fighting the pharmaceutical companies that were charging these impossibly high prices and that were ultimately killing people because they could not gain access to these drugs. So in 1997, there was a court case in South Africa that came out of the amendment of the Medicines Act. And the Medicines Act is one of the key pieces of legislation around this issue. And the amendment was meant to improve access. The sole purpose was to actually unlock access to high-priced medications. And there were a whole range of large pharmaceutical companies that sued the president of South Africa, who was Nelson Mandela at the time. So you can imagine what that was like, suing Nelson Mandela in the case that was, this was the crux of a global campaign. There were lots of things happening in Europe and in the US, but this case became the center of a global campaign around access and pushing back on big pharma and the agenda of profits above people's lives. So that case, I think one of the big learnings from that case was firstly that the use of law and intervening in a court case between pharmaceutical companies and the government was a critical use of the law. And this is the amicus intervention that many countries have, this amicus curiae mechanism. So for the treatment action campaign to enter into a case like that was the first time that it was done, and it was done to great effect. And in fact, in the end, they produced a lot of evidence, and the kind of solidarity that we're seeing today around COVID with experts producing materials for activists to use was really critical. And so in the end, that the pharmaceutical companies withdrew that case because of the tremendous global pressure to do so. So, that was one of the key things, and it was really a patent issue. It was about defending their patents and not wanting to even make an exception around HIV drugs that led to that case. But again, global solidarity as a critical tool for activists now in COVID could not be more clear. And today our tools include social media. And the quick use of webinars and producing information so fast and being able to share it and translate it has become so important. So a lot of the campaigns that Heidi spoke about, we are also part of. So, you know, the WHO efforts, we're also calling on the WHO to do a number of things. So I think that these connections continue to be absolutely important for us. And I think also coming out of that particular case, and there were other cases that unlocked various areas of access to medicines, but that kind of global solidarity played a large role in the Doha Declaration on Public Health, which dealt directly in the WTO with the TRIPS agreement, which then basically said what we all know, which is that governments should be able to protect public health in their own countries, and that they're empowered to do so through this international agreement. And from there, more and more campaigns came out to say, well, we are allowed to have compulsory licensing because the WTO actually allows for that. As much as Big Pharma continues to sue governments around the world, you know, this is a critical kind of piece of, is a critical mechanism for us, working all around the world, including in South Africa, where we have used the Doha Declaration to push for reforms of the intellectual property laws. And after a 10-year struggle, fighting for a new policy that would centralize public health in the intellectual property laws, we were successful, and we had a victory 2 years ago where the intellectual property policy was published and agreed to by cabinet, which allows for the government now to introduce new reforms into the Patents Act primarily, but also related acts that will prioritize public health in the sphere of what are essentially private rights around access to markets and so on. So right now, the next push is to get the legislation drafted, which we've been engaging with the government about, and also pushing that, you know, we table this legislation now, because again, we are in a position where patents can be granted without any examination in South Africa. So, you know, there's Pedro will talk about the campaign around no patents for any COVID-related technologies. But we in South Africa are on the back foot already, because our laws, you know, will grant a patent without any kind of evaluation. So part of what we have to do is to make sure that they don't even get into the door, which, you know, I'm looking forward to the discussion on that. But I think for us as South Africa and African countries, we generally are on the back foot because our health systems are poor. And we have these laws that are limiting our access to equal access globally. And we can't compete, you know. As Heidi says, we're not going to be able to compete with the US and the EU for, you know, PPE, you know, to start with. We don't have enough gloves. We don't, you know, our capacity for manufacturing in this country and all of our countries has been decimated. Because of the rise of China, right? And now we look to China for solutions around vaccines and medicines. And so I think for us, this kind of solidarity is critical to ensure that there is some kind of mechanism from the WHO, commitments from the G20 and so on, from northern countries, that if and when vaccine is developed, that it is declared as a public good, and that there are mechanisms for equal access and for fair access around the world, and for a prioritization based on need, not on the ability to afford those technologies. I'll stop there. Thank you.
That was great. Thanks very much, Umunyana. Yeah, we can't really hear, you know, everybody clapping, but I'm sure they would be if we were in the room. So yeah, that was great. Just to say, before I hand over to Pedro, if people have questions to any of the panelists, you don't need to wait until everyone's finished speaking to put them in the Q&A. Stick them in there now, and we'll be able to have a look at them and try and make a kind of well-flowing conversation at the end. I'll now hand over to Pedro to talk about the situation in Brazil. Thanks.
Thanks, James. Hello, everyone. Thank you, Global Justice Now, for this invitation and a really important webinar. So here's what I will try to pass on as a message. So the first, I'll start with some Brazilian context, because I think it's very difficult to understand what's going on now in Brazil without a proper discussion on the context, on the political context. And then I'll talk about a little bit of the Brazilian response to coronavirus and how the civil society is organizing to jump in this discussion. So very briefly with the context, so Brazil is governed by this ultra-right wing government, and our president is Jair Bolsonaro, which is a former military man who was expelled from the army. Some members of the cabinet of Jair Bolsonaro believe the earth is flat, believe it or not, but they defend this idea. They think our Minister of Foreign Relations said publicly that global warming is a communist plot. And there's an automatic alignment with the Donald Trump government. And the president himself holds a deep contempt by science and all kinds of knowledge. Since the beginning of the epidemic, the president has been saying constantly, no, this is just a little flu, this is not a big deal, this is a Chinese conspiration to undermine Brazilian economic growth, which was not going on actually. And in the middle of the pandemic, when Brazil had nearly 1,000 people that died for coronavirus, he went to the national broadcast television and he said publicly that people were overreacting, that we should suspend all social isolation measures because it was just a flu. He also participated in several demonstrations where there are many people together without any masks, cleaning his nose with his hand and shaking hands with his supporters. So he's like the anti-COVID-19 icon, I believe. Now, our Minister of Health is a businessman. He says he's a doctor, but he can't even put a mask on. He's a businessman who walked around in the country for the last 20 years trying to sell private plans for people and trying to undermine the public health system. Now he's in charge of the public health system. And lastly, last week, the president fired his most popular minister, which was Sergio Moro, a former judge who arrested former President Lula for corruption. And 8 months later, he got a job in the government he helped to elect when he put away the main contester of Jair Bolsonaro. So this is a little bit what's going on right now, and how Brazil is responding to COVID-19. I think we have to differentiate very much the federal sphere response from the state and the municipalities' responses, which are being very heterogeneous across country. Brazil is a very big country with more than 200 million people. So in the middle of the crisis, the president fired the Minister of Health because they disagreed about the social isolation measures. The president said this was going too far, that Brazil was going to break. We need to reopen businesses because people would starve. And actually, he was waiving his responsibility as head of state to keep these people at home and and pay this basic universal income, which is now being done. But anyway, what kind of country just fires his Ministry of Health in the middle of this great pandemic. So Brazil was not prepared at all, despite the fact that the WHO had declared the pandemic many months ago. There are no advanced purchase of tests, individual protection equipments, and etc. And because of this unpreparedness, the federal government insists on this fake dilemma, which is health versus economy. The president says that if we don't reopen the country will break, that people will die from starve and not from the virus, which is absolutely ridiculous, because the state has to guarantee that people need to stay home and need to guarantee this basic income, which is now a little bit more than $120 per family. So before that, Brazil was already facing an important economic crisis, and financial and economic elites are pressuring to reopen everything and are being backed up by the president. But currently, what is happening now, cases are growing very rapidly, and several scholars are saying that Brazil could be the next epicenter of the epidemic after the United States. 7 days ago, we had 80,000 cases, and now we have 130,000 cases. So in 7 days, we have almost doubled our number of cases. Yesterday, Brazil registered the highest number on terms of deaths, and in terms of new cases. Just yesterday, 10,000 new cases were registered. But at the same time, there's this huge under how do you say that in English? I'm sorry, underreporting of cases. Brazil has the lowest testing rate amongst the 15th most affected countries by coronavirus, with just 1,500 tests per 1 million inhabitants, which is very low. And there are no tests, and a very small room to increase laboratorial capacity to process the tests, if there were tests available. So we are now past 80,500 deaths, and a fatality rate of 6.8%, and which is not as high as some European countries, but it's not low as well. And a few days ago, Brazilian president was asked that when Brazil passed 5,000 deaths, and the press asked him, so Brazil has passed China with more than 5,000 people died. What do you say? And he said, so what? I cannot operate any miracles. What do you want me to do? That's the level of our president. So despite that, some governors are trying to do a good job, but exactly as Umunyana and Heidi tried to share a little bit before, several purchases of critical technologies are being stuck in the global north. There was this case when Brazil and Brazilian states, they formed a consortium to try to gain scale and purchase mechanical ventilators. And it was going through Miami from China. And the government of Florida arrested the purchase and said, no, this stays here. And it was not possible to bring it over to Brazil. And the Ministry of Foreign Relations did nothing because they are friends with Trump. So what is civil society doing? We believe that In our expertise, considering that we've been working with the field of access to medicines and intellectual property for more than 15 years now, we tried to come up with solutions so that the country could have purchased options and low prices, considering that everything in a pandemic is more difficult. So we are backing up this law bill number 1462. That is a way to expedite compulsory licenses. As said before, the compulsory license allows the government to suspend a monopoly given by these patent, and with that the government can buy from many sources with lower prices. So this is kind of a fast track that because it does not rely on any specific act of the federal administration, rather it's triggered by either the WHO declaration of pandemic, the level 6 declaration, or by the national emergency declared by the competent national authority. So there's no specific act on compulsory licenses, rather it's the declaration of pandemic or national emergency, which is really, really good because it makes things really faster and the way the pace should be in a pandemic. So now, why this is important? COVID-19 is exposing severe inequalities around the world, especially between global and south and global north, south, sorry, global south and global north. In terms of access to technologies, even existing ones such as respirators, masks, gloves. Several southern countries are not being able to purchase those important technologies because richer countries pay prices above the market level. So if there is a proven vaccine or proven treatment with efficacy and safety, it's very unlikely that southern countries from global south will be able to access those technologies, either because there's a limited manufacturing capacity by several firms, either because the production will very likely remain in the global north, in the US and the European Union countries. So Brazil has to guarantee that there will be no monopolies at all in these to these technologies, because then we can either try to produce it locally or to purchase from another source that will not rely on any European or American company. And I think the lesson that we can withdraw from this law bill, which is very important, is that monopolies, they don't fit pandemics. It's impossible to think pandemics with monopolies. I think I could say that to public health in general, and I think we should starting to say that as the new normal. You know, there can be no pharmaceutical patents for any health technologies. It's just there's this recent article by, thank you, James, recent article by Joseph Stiglitz and a couple of more authors that say that we cannot rely anymore on this innovation system driven by profit and based on monopolies, because millions of people have died waiting for drugs that are available and they just didn't reach who they were supposed to reach. And I think the COVID-19 will again expose this very, very, very clearly, because once we have a technology that can fight this disease, it's very clear who will have access and who won't. And the people and the populations that are historically marginalized will keep being marginalized unless we not rely anymore on the goodwill of those companies. And we pressure our governments very hard to say that, okay, we need these technologies when they are ready, and we need it urgently. And we cannot allow any corporation to have any kind of monopoly and any kind of control over this very important health technology. I think I'll stop here, but I'm happy to answer questions in the Q&A part. Thank you very much.
Fantastic. Yes. Round of applause for Pedro as well. I mean, I don't know about you, but I think one of the things I've been really enjoying about the fact that we've had to transform all our kind of public meetings into webinars is how much easier it is to hear directly from people all over the world about the struggles that they're engaged in, and therefore to, you know, to join those things up. And so, you know, that's been a really standout feature for me of these webinars that we've been holding, and I know, you know, other organizations have been holding as well. So thanks to both of you. We've got a whole bunch of questions. I'm going to kind of try and group them together a little bit, and I'm also going to ask you to respond as briefly as possible, because we've got very long. I want to make sure we finish by 8 o'clock, because we have developed a tradition in the UK here on a Thursday night at 8 o'clock of everybody going outside onto their front garden or their balcony or whatever it is and clapping for workers in the National Health Service. So I don't want to prevent anyone from doing that. So we'll finish by 8 o'clock. But I wanted to just, I guess, the first thing I wanted to just come to, because you mentioned, Heidi, and Umunyana, you mentioned it as well, about the campaign for the World Health Organization for a global pooling mechanism. But I wanted just to get a sense of what, where that was at, really. Was it just kind of pie in the sky? Is there real developments on it? I know I know Costa Rica has sort of officially proposed it to the WHO. Is that so? But like, what is there other support for that, and what chances have we of actually getting it?
So because Costa Rica, the president and health minister wrote to the WHO. I think mid-March, but my dates are all becoming foggy now. But yeah, so they wrote to them with this proposal to set up a global pooling mechanism. It was welcomed by the WHO's Director General, Tedros, but it was also welcomed later by UNAIDS and Medicine Patent Pool, which are other kind of global institutions that work on access. The EU has now drafted a resolution. There's going to be, so there's a World Health Assembly that takes place every year. It takes place normally for 10 days in the middle of May. This year they've decided to do it for 4 hours in one day. Not quite sure how that's going to look and feel. So they've actually truncated a 10-day World Health Assembly into 4 or 5 hours over one day, and the only thing on the agenda is going to be a COVID-19 response. So the EU has drafted a resolution called the COVID-19 response. In there includes a whole range of stuff, but also includes this idea of a global pool. So currently the member states of the WHO are now kind of in negotiations to work on that draft. The draft that did come out, we as civil society, certainly in the UK, and maybe Umunyana could speak about whether South Africans have looked at it as well, we felt that the draft wasn't strong enough. And we've put in a consultation response direct to the EU to identify where it needs to be strengthened. So for example, we want to see an affirmation of what's called TRIPS flexibilities in there. So for example, there's a global trade agreement called Trade in Intellectual Property Aspects of Internet, sorry. There's a global agreement on intellectual property aspects of trade, sorry, and that's the TRIPS agreement. And then, as Umunyana mentioned earlier, there was an affirmation of the use of things like compulsory licensing in the Doha Declaration of 2001. And we want to see, for example, this EU resolution to include an affirmation of that. We also want to see, for example, compulsory and mandatory sharing. We don't want this to be a voluntary pool. We also want to see a geographical reach for all countries, not just for low-income countries. We want to see middle-income countries, high-income countries, all countries of WHO WHO being able to access this pool. So those are some of the areas that we want to see it being strengthened. Whether that's actually going to be the case or not, the negotiations are still happening, but we're hoping that by next week at some point there will be some kind of draft that'll be circulating, and we'll make our decisions about whether we want to, as civil society, push for that, for our government to back it or not. But the World Health Assembly is on the 18th of May, which is a week on Monday. Umunyana, I don't know if you want to sort of add anything from South African civil society and their perspectives on the draft and the resolution.
Yeah, just to say that we are in the same position as you, and those are the very same issues that we've been raising. And just to say that I think that these, you know, James, you said, is this going to be a thing? Is it going to happen? I think we have to take every opportunity to be in places of power and influence power. We often are not at the table in these kinds of discussions, and so we have to go and lobby the EU or lobby our governments to take positions. But I think utilizing these kinds of tools and platforms is an important form of activism, and that can be incredibly effective. And we've seen, you know, the expansion of different kinds of actors in these spaces. You know, you'll find the foundations like the Bill and Melinda Gates Foundation, for example, will be sitting in these platforms, even though we as civil society may not be. And so I think it's important to understand where allies lie, and to use those connections to push on the kinds of issues that Heidi has spoken about. Thanks.
Okay, great. So one of the I suppose one of the areas of questions that's come up is really, I suppose, about the nature of the pharmaceutical industry itself. So, for instance, Andrew asked, he said it's true that big pharma dominates the market and accounts for a big share of research budgets. However, I think that smaller companies exist both in the global north and the global south, often manufacturing generic drugs at lower prices. To what extent are they part of the solution? And I mean, there was another question about the extent to which governments, civil society, and the big pharmaceutical companies could or are likely to work together around this pandemic. I mean, I suppose there's a sense there, you know, to what extent has this really changed the game, you know? And then what, I mean, I know, you know, those generic, manufacturers of generics have been important in terms of access to AIDS drugs, for instance, in the global south, right? So, you know, is that something that, but that's only possible in some countries because some countries' patents regimes are more favourable than others, right? So, to what extent could they be part of the solution? Is that what should our attitude be to the pharmaceutical industries? I suppose that's what I'm saying. Anybody who wants.
So is that okay if I answer? Yeah. So I think what's been really interesting is seeing the reaction of big pharma to this pandemic, and they, I think that they are aware that in the current context, it's really difficult for them to be seen as doing anything, you know, like profiteering from this crisis. So, for example, last month, Gilead, who is testing a drug called remdesivir, which is an antiviral drug that they think could be repurposed for COVID-19. They actually they designated this drug as a rare disease drug in the US in order to try and win extra years of monopoly protection on this drug. And when they did that, it was so outrageous because it's obviously not a rare disease drug, that they had massive backlash from campaigners, from the public, and then within a few days they turned around and they withdrew that status. And I think that it's becoming harder for them to behave like that. And we are seeing things like, for example, big pharmaceutical companies are making gestures towards affordable pricing. And so they're sort of making the right kind of sounds. And so, for example, Johnson & Johnson have said that they will make sure that they won't profit during the pandemic. AstraZeneca have said that as well. But the problem, though, with kind of big pharma coming up with their own gestures is that First of all, it's dependent on their own goodwill. Secondly, they define the terms of what they're offering, and like I said, it tends to be off. And they also don't. There also lots of secrecy around their own costs of R&D and the prices they charge. So actually, when they say they're not going to profit during the pandemic, it's very difficult to verify that. But also, if the virus becomes endemic in our societies, actually, even if after this pandemic is over, if we see this coronavirus coming back year after year, then we are going to need vaccines and treatments ongoing beyond the pandemic. And so those promises aren't necessarily going to be sufficient. And so that's why, certainly sort of from our campaign perspective, we've been pushing for more mandatory and binding commitments that governments have to intervene to make those big pharma to try and reshape, I guess, the landscape from which big pharma operate. And you know, transforming the way that we do R&D, the underlying health innovation model, it's been a long time coming. As Umunyana was described, you know, these cracks in the system have been there for decades, and if anything, the coronavirus is bringing them all up to the surface. And actually, now is the time to actually start changing the actual underlying dynamics of the role of governments and big pharma, because ultimately, you know, these health products, whether they're vaccines, treatments, ventilators, whatever, they're not consumer products. At the end of the day, they're all essential to help governments achieve the right to health for their citizens and for people in various communities around the world. In terms of the question about sort of the wider ecosystem of manufacturers, big and small, you know, the biggest problem around manufacturing will be patents. And so actually, so for example, we're calling for any publicly funded vaccine to be patent free, so that you can then use other manufacturers, other companies to be able to manufacture the volumes that to the level of volumes that you're going to need, but also not just to open up the patent, but also to share the know-how and the technology as well. So that's why we need kind of government intervention to kind of intervene to, I guess, to utilize all the manufacturing capability that there is in the world, because we're going to need all of it and more.
I would just add to what Heidi has said. I agree with everything she said. There was a question about how civil society and governments and pharma can or should work together. And I think, you know, as I talked about, the power dynamic is really important here. And as activists, our job is to hold power to account. And I think for us, holding our governments to account is absolutely essential. It's becoming a difficult thing in an environment of a global pandemic to kind of call for accountability in the ways that we are used to doing, because there's such a groundswell of support for the government at this time, how they are working in the interests of public health. And, you know, it's the silly activists that are like, oh, actually, you know, we have constitutional rights that have to be adhered to. We have governance mechanisms. We need oversight. And those kinds of arguments are falling flat, particularly in South Africa, where there's such a high regard for our president's approach. In calling for a lockdown very early on, in kind of being quite transparent and open about plans, the data that's coming out on a daily basis about how many cases and where we're testing, and, you know, who's involved, who are the scientists involved. So when we say, actually, we need more information on the modeling that you're using, that is being used to make decisions that are essentially curtailing rights, those kinds of arguments and accountability is difficult. And I think we have to find ways to continually try to bring to the public's attention that accountability is still necessary, even in the time of a global pandemic, of a crisis. Yes, we must all come together, but there must be parliamentary oversight, for example. We can't just have unaccountable kinds of groups of cabinet members making decisions and not disclosing the modeling they're using, for example. So I think for us to be able to succeed in kind of gaining access to medicines, and ensuring equality, we kind of have to be more of a bad guy than usual. And I think we have to be quite comfortable with that in calling for accountability. But at the same time, I think the question around who are allies in this work is really important, and that will be context specific. Thanks.
Can I add something very quickly, James?
Yeah, absolutely.
So in regards to how do we hold our governments accountable, I really like what you said, Umunyana, and trying to take on something what Heidi mentioned. I think we should think very carefully on how close our government are getting to the corporate interests. And this makes everything harder because there is no defense of public interest. So in terms of, for example, having a compulsory license in the context of pandemic, what should be, obvious? How can we think about monopolies when the whole world is fighting the same disease? It's unthinkable. Yet we have to put on a great struggle and campaigns and try to convince members of the cabinet of something that is obvious. And we are facing huge opposition by the pharmaceutical company that says the same old arguments as always, that there will be less investment in the country. Do they even generate jobs in the global south? That this could hamper innovation. What innovation? Did they really innovate anything for this coronavirus outbreak? As far as I'm concerned, as Heidi showed, they took off the coronavirus research from their portfolio a long time ago, like a decade ago, and now we are seeing that their own prioritization of diabetes, blood pressure, cancer drugs, which are really expensive and widely used in the global north, are causing the world to be in lockdown because we don't have a medicine or a vaccine that can stop this disease. So when thinking about holding our governments accountable, I think we really should expose the ties of the public power to private interests.
And just there was a quick follow-on from this question of working with corporations and so on, which is that somebody asked whether maybe Heidi in particular could comment on the Oxford University AstraZeneca vaccine collaboration, which mentions being affordable in low-income countries. I don't know whether that's something you know, or any of you know anything.
Yeah, no, we actually wrote a letter last week to Oxford University to try and understand the detail behind what's been negotiated. So the Oxford University deal would be an example of UK public funding because Oxford University is a public university, and actually this is what I'm sort of coming across more and more in this campaign, in that there's a lot of good language actually being thrown around at the moment, whether it's the WHO, whether it's the UK government. But actually the devil's in the detail. And actually, even though this deal between AstraZeneca and Oxford University, they've talked about making the drug affordable, but we've heard various confusing and conflicting bits of information. So for example, just a few days before this deal was announced, we heard that the Oxford University had actually lined up a few manufacturers across the world, one of them in India, to actually produce them a vaccine when it came out. And then a couple of days later, we heard this AstraZeneca deal. And we're not entirely sure what this the details in this deal. So what we've done is we wrote a letter to Oxford University, and we set out a number of questions to find out what's, to ask them if they could disclose what is the full terms of the license agreement that Oxford University has negotiated with AstraZeneca. And in particular, we want to understand whether AstraZeneca has agreed to a non-exclusive license. So that, in other words, it means that AstraZeneca has agreed that not only would they manufacture it, but they would open up that license and allow others to manufacture it. We've also asked questions about, for example, whether AstraZeneca will own own the vaccine after the pandemic, and if they will have full monopoly rights after the pandemic. And also we've asked questions about whether there's what safeguards they've actually included in this agreement to ensure that that this vaccine will reach the people who need it most in the world. So there's a whole, so I guess the quick answer is that I'm not entirely sure whether this is a good deal or not good deal. It could be a good deal, in which case we would probably hold it up and say, hey, this is a really good example of how you can openly license some of these technologies. But at the same time, like I said, if we find that the answers to our questions actually that it is just a guise for maybe more of the same, then yeah, then of course we won't be using it as an example. But I guess, like I said, for now we don't know, and I think a lot of this stuff is happening in real time, and we're always trying to find out more information.
There was actually another question earlier on from Stephen about whether what we know about what university departments are involved, are getting public funding, are involved with big pharma. I mean, I think the question was kind of geared towards, is there a way we can put pressure on specific universities, you know? So I don't know if there's any more to be, I mean, maybe very briefly, if there's anything.
Yeah, just okay. Just very briefly is, Stephen, thank you for that question. Basically, yes, I'm working with UAEM, so that's Universities Allied for Essential Medicines. They're a university-based group on access to medicines. They have groups around the world. They have chapters in the UK as well. So I'm working with the UK organisation, and they are, I just heard today that they are producing some data to show where the UK funding has gone. Well, actually, the data is global, but they'll have UK segmented data. So once I get my hands on that, Stephen, I can share that with certainly the Global Justice Now local groups to see whether we want to do any targeting of specific universities in the UK.
And can I just ask Pedro, there was a couple of questions earlier on, sort of questions of clarification about the situation in Brazil. You mentioned something about a universal basic income, a proposal for a universal basic income. Maybe you could just clarify what was going on there. And also there was a question about how much Bolsonaro is really, like how much his views are really supported by the population. I mean, I suppose there's...
The extent of his support, you mean?
Yeah, the extent of his support, but maybe, I mean, it wasn't specified, but I may be also thinking specifically on this issue, on coronavirus. Do people also think, yeah, it's nothing, you know, they don't, you know, or is there starting to be quite a lot of opposition amongst ordinary people to his very dismissive approach?
Okay, so the first question about this emergency basic income, it was a proposal by the parliament, which states that each person that didn't have a proper job before the pandemic outbreak was entitled to receive around $120, $140 per month for the next 3 months. So for instance, you know, people who work autonomously could apply for this kind of emergency income. If this is enough, hardly, this is hardly enough. But sorry guys, I have to change position because I'm running out of battery. So sorry, otherwise I'll get disconnected. And the initial proposal was like, let me think, like $40, and then the opposition in the Congress was able to raise it to $120, $130. Of course, it's not enough for a person to live in Brazil, but it's better than nothing, you know. It should be followed by other measures such as suspending charging of electricity, rent, and etc., such as other countries did. And we also have to remember that Brazil is a very, very unequal country. There was a recent research that said that, if I can remember correctly, the half of the richer population earned 33 times the lower half of the population. So it's a huge gap that we have to face. And in regards to Bolsonaro popularity, he has a core base of supporters that does not go below 30%, which is not very much, but it's not, there's hardly other group that can gather this level of support. So, how can I say, with so much cohesivity, do you understand? They're very united, and they believe very much in what Bolsonaro says, and he can very easily mobilize this 30% of the population, and they're very noisy, and they're willing to go to the streets to demonstrate. And people who are defending social isolation, that are against Bolsonaro, obviously cannot go on the streets. There were very strong demonstrations in the windows. So you guys in the UK, you clap, the health professionals. People are doing very much that in Brazil as well. And one thing I forgot to mention is that our public health system is very much inspired in the NHS. But people are hitting pens in the window whenever Bolsonaro goes to television to make a speech or something. It's very, very noisy. It was not like that. Some political analysts say that he's losing ground in the Congress, especially after the exit of his super Ministry of Justice, this former judge Sergio Moro, which is like which he was the anti-corruption guy. He was facing corruption, and this was when the main things in the Bolsonaro's campaign, to clean the country from corruption. I think this sounds very familiar from many of us, this very magical solutions against corruption that unifies people, because of course no one's pro-corruption, everyone's against corruption, but somehow people manage to put the focus on corruption in a given group. So he lost a lot of popularity, but he has this core 30% base, which is difficult to face.
Okay, thanks. And it goes without saying, we all send our complete solidarity to you in your, the difficult situation you've got with the struggle against Bolsonaro.
Yes, not easy.
Yes.
Thank you.
I just wanted to move to so there was a question earlier on about to what extent can the WHO help as a mechanism, as an institution, to ensure fair access to any COVID-19 vaccine, and will like Trump's government, for instance, just push forward with a nationalist approach regardless? And that also kind of links to another question that was asked about, initially, if there's a vaccine, there'll be limited supplies. So, how do we ensure a kind of fair distribution in the context of limited supplies? So anyone that wants to kick off on that one.
May I very quickly?
Sure, yeah.
No, I think this is the question. This question is not just for future health technologies, for the current technologies that we have. How do we make sure there is equitable distribution amongst the needing countries? Because as Umunyana said before, we cannot even get in gloves, and the masks are like 5 times more expensive than they used to be. In the context of a house, is not very much, but in the context of a public hospital, it's crazy. Because of that, Brazil has lost already more nurses for COVID-19 than Italy and Spain combined. The last number were like 80 nurses have died for coronavirus until I guess last night, which is crazy. How do you lose health professionals in this context? So the question is now, is not when we have a health technology. And I think that the WHO should play an important role. And we also have to think about, not just for this crisis, but a future crisis, how can we develop national capacity to overcome these kind of things? You know, how can we develop local manufacturer capacity in our global south countries so that we can produce our own equipments and so forth.
Great. Umunyana, do you want to add something?
Yeah, I will add. Yeah, I completely agree with what Pedro has said. And I think that the WHO does have a very specific role to convene power. And I think that they should be at the forefront of an international agreement that will put at the forefront the kind of needs-based access. So we say, you know, it should be affordable, but actually it should be where the need is. So there may be countries that have huge numbers of cases for whatever reason. And so for companies to say they'll make the drug affordable isn't enough. Actually, what we need is a collaboration and commitment. And that's the kind of thing the WHO can drive as a UN body to ensure that commitment happens and that's binding on companies. So, you know, you'll hear these companies saying, oh, don't worry, it'll be affordable in your countries, but they don't, what does that mean even? What does affordable mean? And so I think we need to push the language around equitable access and on a needs basis rather than an affordability basis.
Great, and we've almost got to stop, but I just want to shoehorn one more question in, and it's probably more directed at Heidi, because there's been a number of questions about, well, what can we do as individuals, maybe as groups, but of course, you know, we've mentioned already, people can financially contribute to our campaign and the campaign of others, and they can take our online actions. But what else can we actually do? Is it that we can, should we be writing to our MPs about supporting the Costa Rica proposal at the World Health Assembly? What is it that what else can people do?
Yeah, so I think, yeah, so we do, so there are specific actions that we've launched. They're all online actions, of course, in the current context. And so we have a petition that I think Liz has shared the link to in the chat. There was a Costa Rica action direct to Matt Hancock, which is our Secretary of State for Health in the UK. That's a government department where we send our delegation to the World Health Assembly. And the World Health Organization. So there is demands towards our government on those two things as well. I mean, the other thing that I feel like people could do as well, which I think is really important for this campaign, is going to be, it's about spreading awareness and helping to talk about these issues and talk about, because a vaccine is potentially 12 to 18 months away, but the fight to ensure equitable access happens now. And so that's why we need to kind of spread the word as quick as we can, but also when the UK government joined a WHO initiative last week to commit to equitable access. But if you were to question the government further, what does it actually mean? There is no plan of action behind that. There is no commitment to suspending patents. There is no commitment to ensuring publicly funded vaccines and drugs will be patent free. So I think this is where we as campaigners kind of keep pushing and prodding and to start to begin to change the narrative around drugs and vaccines to say they're not commodities to pay profit from, but they're essential to our right to health, both here in this country and around the world.
Fantastic. Well, listen, there's some more links coming up in the chat there. I'm gonna wrap up now because I'm sure that the clapping for the NHS is going to break out any second if previous weeks are anything to go by. Thanks once again to all our speakers, but especially for Pedro and Umunyana for taking the time to join us. I think this has been a really, really interesting and inspiring webinar. Yeah, I hope everybody else has enjoyed it as well. And it motivates you to go out, well, not go out there exactly, but get active to support this campaign, which is really, really important for millions and millions of people around the world. So thanks once again. We're going to stop the recording now, and then we'll probably just hang around for a few more minutes so people can use the links in the chat and so on. But thanks very much, everyone.